Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth. And I'm your host for our program tonight on arthritis. We would be very happy to answer your questions about the diagnosis and treatment of arthritis, bursitis, tendonitis, and rheumatoid arthritis. Remember that the success of this program really depends upon you, the viewer. Please call in your questions, and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Tonight, I'm pleased to welcome our panelist, Dr. Gail Baldwin, a family medicine physician from the VA Clinic in Superior, Dr. Robert Leff, a rheumatologist with Essentia Health Duluth Clinic, and Dr. Cynthia Weaver, a rheumatologist with St. Luke's Rheumatology Associates. Our medical students answering the phone tonight are Carl Coivisto from Cokato, Minnesota, Emma Sealing of Alexandria, Minnesota, and Cammie Young from Vernon Center, Minnesota. And now on to our program tonight on arthritis. Dr. Baldwin, at the VA, I'm sure that you see a lot of arthritis. Could you tell us what arthritis is?
Well, the term really stands for inflammation of the joint. Arth refers to the joint and itis refers to the inflammation. So it's inflammation of the joint, and it can be due to many things. It can be infectious, it can be inflammatory, it can be autoimmune. Lots of different things can cause arthritis.
Dr. Leff, as a rheumatologist, I know that you see a lot of rheumatoid arthritis. Do you want to talk about what the pathology or what rheumatoid arthritis is?
Well, rheumatoid arthritis, Ray, is a clinical diagnosis of a symmetrical polyarthritis. That means if you draw a line down the middle, people get many joints involved on this hand, they'll get it on that hand, lower extremities, both sides. So it's symmetrical, many joints. It's clinical. It usually occurs in the 30s to 50s, but you can have it as a little child or an elderly person. And it's a disease that's not just of joints, it's systemic, meaning that the immune system in your blood is abnormal. You have B cells and T cells that can talk to each other, and they become out of whack, and then it can cause you not only to get arthritis problems, but skin problems, eye problems. You can even have heart and lung problems associated with it. And so it's not just a joint problem, it's systemic, diffuse disease.
Very interesting. Dr. Weaver, another arthritis type that we hear a lot about, especially those of us that are getting older, is osteoarthritis. Do you want to inform us a little bit about osteoarthritis?
Osteoarthritis is probably the most common type of arthritis that we see, and really has to do more with that the cushion in the joint starts to wear out. It's always traditionally been thought of as sort of a wear and tear disease, but we understand there's probably a lot of things that may have to do with the immune system that can affect that as well. There's a lot of things that have to do with whether you're going to get osteoarthritis or not. One is how much you weigh. We find that every 20 pounds over ideal weight doubles your risk for developing osteoarthritis of the knee. If you think about it, it's just that constant pressure overloading the joint. Also, we know that fat cells, even though we think of it as just things that lay around and do nothing, actually produce some things that cause bone spurs to grow, which is leptin, which is something that also controls appetite. Damage to a joint is more likely to cause osteoarthritis in that joint. Probably also inherited diseases are some of the things that we see it with.
Dr. Baldwin, as family physicians, we see a lot of tendonitis and bursitis. Do you want to talk about those just a little bit?
Well, tendons are some of the things that hold your bones together, if you want to say that, and bursas are the little fluid sacs that kind of cushion the joint and allow the connective tissue to move more smoothly as you move your joints. And so when a bursa or a tendon becomes inflamed, you'll get redness and heat and swelling. The joint will feel like, some people call it arthritis, but it is indeed more the connective tissue than it is the bones or the cartilage itself that is inflamed. Sometimes it can happen because it's been injured, sometimes it can happen for other reasons, but injury is a common cause, or strains are a common cause of inflammation of these tissues.
So like overuse type things?
Yeah.
Running or tennis or something in that order.
Yes.
What kind of treatment do you use for, say, tendonitis?
Well, if it's early on after an injury, I usually suggest doing things that are fairly simple, things like ice or alternate ice with heat initially to try and reduce the swelling and induce some comfort. Sometimes nonsteroidal drugs like ibuprofen, Aleve, that sort of thing, to help alleviate the symptoms. A little bit of rest, though continued movement, I think, is still important. So total rest, like putting someone in a sling, is not usually what I will do. But I do ask people to, if they're doing the same things that injured the joint in the first place, to kind of lay off.
After a few questions, and after we've talked a little bit about this, remember to call in your questions tonight. The number's 728-2844 locally, and 1-877-307-8762 toll free. 877-307-8762 and 728-2844 locally. Dr. Leff, back to rheumatoid arthritis. Can you have rheumatoid arthritis in the eye?
Yes.
You covered a whole lot of other places.
Yeah, you can. What happens, there's something called iritis, or some people call it uveitis. They're different terms. But there's three components of the eye that can get inflamed, and it can be associated with rheumatoid arthritis. And if it's severe enough, it can cause blindness. It usually presents with dryness and a lot of redness in the white part, the sclera of the eye. But then it can cause problems with the iris, which is the thing that helps to dilate or contract when you have light exposed to it. And then you have problems where you can't open it properly when you go from a dark room to a light room. And it can be quite painful. So it's a medical emergency. It needs to be treated aggressively.
Dr. Weaver, there's questions about arthritis of the spine. This person had a cortisone shot to help with spine pain when getting out of bed. Mm-hmm. Now she has a sharp pain below the hip when she gets out of bed. Is there any relation? What could be causing that? Any treatment ideas?
I guess it depends a little bit as to where she describes the pain. If it's right over the buttock going down, it could be the sciatic nerve. And if it's on the outside of the hip, it could be something more like bursitis, just as Gail was talking about a little earlier. And oftentimes you see if people have had a little bit of an abnormal gait, they're more likely to get bursitis in the hip. And so I guess there's a lot of ways that you could look to figure that out. One, obviously, is physical exam could tell you a lot about whether they might have bursitis. An x-ray might tell you, is there arthritis in the hip causing it? An exam that looks at the neurologic system could tell you, is this something that has to do with the sciatic nerve or a nerve that's being put pressure on, or even MRI? So I guess I don't know entirely the answer, but there's a lot of possibilities.
Thank you. Again, apparently we're having some phone number difficulties. The correct phone number locally is 218-788-2844. 788-2844. Thank you. Spinal stenosis, Dr. Baldwin. Is that a form of osteoarthritis? Well,
it could. There are some arthritis conditions that can cause narrowing of the place where the nerves come out of the spine, and spinal stenosis is basically a narrowing of an area where the spinal nerves in that area of the back live. So if arthritis or inflammation causes deposition of calcium or bone to reduce the opening, then that can result in a stenosis or a narrowing of the place where the nerves come out.
Question that I would open up to all of you, is there anything that you can do with multiple connective tissue diseases diet-wise? Is there anything in diet? And I suppose this is a good time to talk about prevention and exercise or other things.
Yeah. Well, I know Cindy mentioned earlier about osteoarthritis and weight. Just to give you perspective, when you bend your knee and squat, you put 7 times your weight through your knee, or about that. And so if you're 20 pounds overweight, you multiply it by 7, there's an extra 140 pounds. And that's why people don't like to squat or kneel when they're really heavy. And just older people, not that any of us are old here, but older people don't like to squat either because the cartilage starts to go. And even if you're normal weight, it's hard to do that squat. So weight reduction, or being at a normal BMI, normal weight per height, is the best thing. Maybe you have other comments about dietary restrictions or things.
What I tell you is that's probably one of the most common questions I get from patients is, what can I do to change my diet that's going to make this go away? First of all, I wish I could tell you that I had the magic to make it go away, just diet, because I'd never give anybody a drug if that was true. But of course, I don't have that. There probably is some diets that are a little more anti-inflammatory than others. I mean, if you think about the typical Western diet and you say, you know, going to McDonald's every night, and that's probably a little bit more of what we think of as an inflammatory diet that causes more inflammation in the body. Things that are an anti-inflammatory diet are things that are more like what you talk about with a low cholesterol diet. So plenty of fresh fruits and vegetables, low-fat dairy products, limiting probably the fatty meats. You know, we all know that bacon's probably not the best for us, even though it tastes great. But so probably no more than like 4 ounces of meat at a time are the kinds of things that help people to have more of an inflammatory diet. Does it also cause you to lose weight, and that helps? Absolutely. That's all true with that.
Yeah.
And in fairness to McDonald's, they now have salads.
Oh,
and
you're right. You can have better choices.
Well, the other thing is sprue, which is a condition that can cause inflammation. Some people have a gluten sensitivity that will result in inflammatory problems. So sometimes there's something called an elimination diet, where basically you can either start by eliminating everything and then adding things back little by little, or you eliminate things that are sort of notorious. So if you eliminate all wheat products, if you're concerned that that might be an inflammatory agent in your diet, it's a little easier to do now. Lots of places have gluten-free things that you can eat, even if you're eating out. And then do that for a few months, or at least a couple of months, to see, does it make a difference? If it does, great, stay with it. If it doesn't, well, then you can go back to eating the foods that have gluten in them, knowing that it's probably not the cause of your inflammation.
Yeah, and that's a great answer, and that's what I tell patients too. Some other things that sometimes that have been sort of considered to be culprits. I mean, people talk about like the nightshade vegetables, which means things like potatoes and tomatoes and peppers. But I'd have to say I think that's probably kind of an old wives' tale in a lot of ways, because they have found that people that eat a Mediterranean diet actually probably have less inflammation in some ways.
Yeah.
And so in Mediterranean food, we all know, hey, that's like tomato sauce.
Right.
So,
olive oil.
yeah, and so actually it probably is not true. But elimination is probably one way you can figure out is your diet have anything to do with your arthritis? And things like milk products and also gluten are probably things that we talk about for patients. And some patients find it successful, probably most patients don't.
How about the use of glucosamine or chondroitin?
Good question.
You can find a study that'll tell you either answer you're looking for. So I tell people to give it a try for a couple of months. If it does some good, great. Then you've found something that's very helpful to you. There's little downside with that combination as far as I know.
Right.
It does have anti-pain effects, but it really hasn't been proven to have anti-inflammatory effects, Ray. So it can be helpful for pain. Yeah, certainly in osteoarthritis, but from an inflammatory standpoint, it's still out there.
Yeah. Actually, did you do the GATE trial?
I
also?
did.
Yeah.
Yeah.
That the GATE trial, it's probably been over a decade ago now, maybe close to that.
Yeah.
It was a trial that was sponsored by NIH, and both Dr. Leff and I had patients that were involved in that. What they looked at with that was glucosamine and chondroitin versus Celebrex in patients with osteoarthritis. And the goal at that time was, are we able to show that this really is something that stops arthritis? Well, the answer was, as Dr. Leff said, we found they still had joint space narrowing. You know, it didn't stop arthritis changes. But they found that probably about a third of the patients that took glucosamine and chondroitin actually had some relief of pain, about the same as Celebrex. But that's only a third. That's only 1 in 3. And so for some patients, it is helpful for pain, as you said.
Immune modifying agents, are they helpful?
Depends on your kind of arthritis.
Rheumatoid arthritis.
Sure.
Yeah,
go
And,
ahead.
and the next question is, how do you choose which one?
Well,
That's a great question.
I think you
And now
look,
Rob is on the spot.
you look at different syndromes, and so it's not for osteoarthritis. It's for diseases, for example, rheumatoid arthritis, psoriatic arthritis, a few other diseases. And there are many kinds of immune modifiers. These are drugs such as the TNF inhibitors. People may see them on TV as Enbrel, Remicade, Humira, and some others. And then there are other drugs that block other inflammatory components, and these are called Actemra or Xeljanz. And they all have their advantages, Ray. As far as when do you use them? Well, all I can say is that if you use baseline drugs like methotrexate first for rheumatoid arthritis, or sulfasalazine or Plaquenil, if these drugs don't work, then you start thinking, maybe I should use one of the immune modifying drugs. But it depends on the individual which one you go with.
Dr. Weaver, we had a little discussion before coming out tonight regarding the biological
Right.
drugs, and as MNsure cranks up, do you want to tell us what what you've heard
Yeah,
or are concerned about?
I guess I do have a couple concerns. I have a lot of patients that take biologic agents. We use them all the time for rheumatoid arthritis, psoriatic arthritis, and I'm concerned as to whether some of the new insurance plans are going to pay for those, because I had received some information saying that some of the cheaper plans may pay for only 40% of the cost of a biologic agent. And so I think that's what's most important for my patients to know is you need to make sure that you actually check with your pharmacist, check with your insurance agent, that the plan you're going to get is going to cover the medications you have, because these medications are incredibly expensive.
How much do they cost about a year?
Yeah.
20,000?
Yeah, it depends on the drug a little
Yeah.
bit, but and the dose, but about 20,000 a year probably for most of them.
So it's important to know
So, yeah,
what your coverage is
yeah,
going to be.
if you don't have a plan that pays for it, you could be in trouble.
Gouty arthritis, Dr. Baldwin,
Yes.
can you tell us what that is?
Well, gouty arthritis is when uric acid crystals cause inflammation in the joints, and it really is a very damaging arthritis. The crystals really do a lot of damage in there. The uric acid crystals come, sometimes it's a genetic thing. Some families tend to have gout more than other families, and it certainly can be affected by diet. There are certain foods and things that you shouldn't eat to avoid getting extra uric acid forming in your joints. When people are prone to developing gout and get dehydrated, that's when we start to see usually the worst times when they get it. And usually the first time the joint is inflamed is the worst time the joint. No.
I was thinking not always.
Not always. Okay.
Yeah.
It seems like.
That's probably when you see them a lot of times.
That's
yeah.
what it seems like when I see people. It's the first time they're probably because they're so shocked by, holy smokes, you
that they
can't
get
even
this horrible
touch this
pain.
with your covers.
Yeah.
You know,
Yep.
it hurts so bad that anybody gets close, you start to sweat.
Yeah.
So-
And partly my patient population is probably the people that have had horrible disease that it wasn't a first-time deal, so I
Yep.
see a little different population.
Yeah.
Gout is something that's really increasing in incidence, and I think probably related to things like obesity. And you see that body mass index, which means sort of the size of your body, is related in some ways to probably uric acid production. And as we become bigger people, more gout. High fructose corn syrup is actually one of the foods also that they think is related to gout, which is in everything. So if you drink a 12-pack of Coke a day, well, gosh, you just drank a whole bunch of high fructose corn syrup.
Yeah.
And so that's one thing that you don't really think about as
Yeah.
being associated with gout, but is.
Yeah.
Can scarlet fever as a child lead to rheumatoid arthritis later in life?
Two separate entities entirely, Ray. And scarlet fever is related to a strep infection, and rheumatoid arthritis, totally different problems, so the answer would be no.
Polymyalgia rheumatica.
Okay.
Can you discuss that?
Oh,
just
sure,
briefly?
absolutely. Polymyalgia rheumatica is a disease that we see primarily in older people and generally presents after the age of 50 and is more common actually in people of Northern European descent. So we see it pretty commonly in this population here. Patients usually present with shoulder pain, hip pain, morning stiffness, and it's a disease that's treated primarily with corticosteroids. I mean, they are looking at studies of other agents that may work for that, but right now, probably steroids are the best we have for that. It is one of the few things that we see a lot of times patients are not on lifetime drugs. We see probably about 70% of people will be off their medication in a year with that. Most of my other patients with arthritis, you're going to get it for a lifetime. You're going to be on a medication to be treating it. The complication we worry about with that is temporal arteritis, which is inflammation of the arteries that lead to the eye, which can cause blindness. So it's important, obviously, to treat this and to monitor for that.
Rob, methotrexate, how long can a person be on it?
Well, methotrexate's medication. It's given orally or it can be given in shot form. You use it for different syndromes, for example, rheumatoid arthritis, psoriatic arthritis, some other things. And it can be given for many, many years. It really started to come into prominence for rheumatoid arthritis about 1982, 1983, and there are people who have been on it for 15, 18 years. You have to monitor it with blood work, looking at their liver, looking for anemia, that sort of thing. And it's generally pretty well tolerated. It can cause lung problems in a rare group of people. It can cause hair loss. But as long as you monitor it, I think it's safe to take it for many, many years.
What are the long-term effects of using sodium alendronate for osteoporosis? And the short-term effects. You guys want to enter into that or not?
Want me to take it? Or?
Sure, go right
Whoever
ahead.
wants to jump. Okay.
This is a big question.
Yeah,
All right.
big question, we can.
It's also known as Fosamax. It's part of the group of drugs called bisphosphonates. I call it the Sally Fields drug. I mean, it's that class of drugs. You see Sally Fields on TV hawking the drug. But that class of drugs can be used to prevent and also treat osteoporosis. And occasionally people can get a GI upset where they have heartburn when they take it. But it's generally well tolerated. Long term, particularly statistics say if you take it more than 5 years, you can have what are called atypical fractures of the femur. Most people who break the femur, the thigh bone, break it up here. But you can break it lower down just spontaneously because of being on this drug. It makes it a little brittle. Occasionally you can have, and this is very rare, what's called AVN, avascular necrosis of the jaw, where people will have the gums just recede and they can have a bone infection. What else, Cindy, would you?
Well, first of all, I'd like to say that the side effects you just talked about are actually very, very rare. I have yet to see somebody who's had an atypical fracture of the hip, but knock on wood, I guess. So, but these medications are also incredibly good medications. They probably reduce the incidence of fracture by about 50%. And once people have a hip fracture, mortality rate is about 20% the year following that. And that means your chances of dying the year after you have a hip fracture is about 20%. So it's absolutely important to try and prevent that. And even though there are potential side effects, they're rare. And when you look at things like osteonecrosis of the jaw, the concerns are for people particularly that have had dental trauma. So what we ask patients to do is generally to go see your dentist beforehand, before you start with these medicines. You know, and if you have to have a tooth pulled, have it pulled beforehand. And so good dental hygiene makes a difference with those kind of things. It's preventative for that. Generally, they're well tolerated, and I think they're very effective meds.
Do you stop them after 5 years, give them a holiday, and then go
A lot of
back?
times we do.
Okay.
And we continue to monitor bone density. Usually I do a bone density every couple years on that. If they've had a loss of more than 4% in bone density, we restart the medicine. For patients who, if you're really, really high risk, say that you've had multiple fractures and you need this medicine and you're on 60 milligrams of prednisone and chances of breaking something are bad, I probably would talk to you about maybe not taking a drug holiday for that and continue with the drug.
Or use a different drug.
Or use a different drug.
class. Because there are
If you
other
can.
drugs,
if you can.
yeah, right.
Okay.
Gail, several questions on the treatment options for spinal stenosis, and I don't think we really went there in our discussion, or any of you can jump in. So the pain management and treatment for spinal stenosis. Thoughts?
Boy, well, microsurgery and some of the surgical techniques make doing surgery on that area of the spine a whole lot more of an option even later in life, but that's the last resort. You know, usually trying to get people to improve their posture, core strengthening, and then try to do pain management techniques. And that's pretty much my therapeutic. And then if it's so debilitating that someone really needs surgery, then I'll talk to the neurosurgeon and ask if this is appropriate.
So do we do laser surgery for this in Minnesota? This is a question. Apparently, I'd never heard of that. But
I'm not aware.
I'm not aware of it if it's being done. It's usually pretty major surgery. It's not a simple
Yes.
disc surgery.
It's
It's a major surgical procedure.
question about tendonitis in the thumbs. And I'm not sure if we're talking really about tendonitis or if we're talking about arthritis in the hip joint of the hand. you want to talk about that? And apparently this person's had some cortisone shots. Are there some other steps that can be done?
Well, some people do joint replacements on the thumb if it gets bad enough, but that's sort of far down the road.
Yeah.
You can also use a thumb post or a spica splint that basically just comes over the thumb around the wrist, and they can still move their fingers. It just rests it. It's like a cast that you can take on and off, and that can give you some relief.
So will texting as a child cause problems later? That's a question of the
We don't
time.
know that yet. They haven't.
They'll get mega thumbs. They'll get huge thumbs. No, I don't know.
I want to thank our panelists tonight, Dr. Gail Baldwin, Dr. Robert Leff, and Dr. Cynthia Weaver, and our medical students, Carl Koivisto, Emma Sealing, and Cammie Young. Next week, Dr. Alan Johns will have a program on orthopedic problems and joint replacement. His panelists will be Dr. Dave Hutchinson, Dr. David Rust, and Dr. Joseph Signorelli. Thank you for watching, and have a great night.